be made. In smears where there's copious amounts of colloid, such as in a colloid nodule where you don't see a lot of follicular cells, or very few follicular cells, those can also be called benign. Okay, so category 1 is benign, and in this category you see the colloid nodule, you see the follicular adenomatous nodule, which are basically colloid nodules or goiters. The Hashimoto's or chronic lymphocytic thyroiditis is also in the benign category. So what do we see? What are benign follicular cells? These are small, uniform follicular cells. They're they have honeycomb sheaths, which means that they're spaced apart evenly, and they appear in sheaths. Rarely you see single cells, but I do see single cells on a regular basis as well. And sometimes you can aspirate intact follicles. So these are benign follicular cells. This is the Diff-Quick stain, and you see that the follicular cells appear as dark purple cells. Some of these have follicular arrangements. They're in small groups. They're evenly spaced out for the most part. There are some single cells in the background, but mostly they're in small groups. Here's another picture of follicular cells, also the same stain. You see some blood in the background, but you see these small, round, purple cells, which are the nuclei of follicular cells. You can also see Hürthle cells in the normal thyroid gland. These are also known as oncocytes. They have finely granular cytoplasm that is abundant. Sometimes the nuclei are a little bit large, and they may have nucleoli. You can see binucleated and multinucleated forms. You can also see them most commonly associated with Hashimoto's thyroiditis, but you can also see them as metaplastic in nodular goiter, as well as Hürthle cell neoplasms, which of course are not normal. Those are neoplastic, and those would be a category 3 or a category 4 even. This is what Hürthle cells look like. On the Diff-Quick, you can see they have these dark purple nuclei with abundant cytoplasm. You can really see the cytoplasm. It kind of looks like a cobblestone form. On the right, you see the pap stain, and you can see what the differences are. The nuclei are the dark blue cells, and they have prominent nucleoli. That's a very dark spot in the center. You also have abundant granular-looking light blue cytoplasm. Other things that you can see on an FNA slide of the thyroid are ciliated cells, which are respiratory epithelial cells, which means that, oops, you accidentally entered the trachea. Clinically, if you do enter the trachea during the aspiration biopsy, the patient is probably going to be coughing. So that's a telltale sign. You can also see fibrocartilage if you go through. You could be going through some areas in the neck where there's fibrocartilage. You can see skeletal muscle. The sternocleidomastoid sometimes is between the needle and the thyroid when you do your stick. It's painful for patients when muscle is gone through during an aspiration biopsy, and a patient may feel a lot of pain afterwards, after the procedure. Because you're going through skin or you're going through adipose tissue, you may see that as well on the slide. So cystic lesions are usually benign. We commonly see cystic lesions. They appear anechoic or usually anechoic on ultrasound. You have to see the follicular cell component to rule out a cystic PTC. And like I mentioned before, some cytopathologists do call these unsatisfactory. And this is what a cystic lesion looks like on FNA on the slide. This is a Pap stain, and what you see here are foamy macrophages, and the areas that look with the brown pigment are hemosiderin. So it's old blood, dried blood, which the macrophages are consuming. So this, if there are follicular cells present and you determine this as a satisfactory specimen, this may be called a colloid nodule with post-hemorrhagic cystic change. This is, again, also another couple views of what cystic change looks like. On the left picture, you see foamy macrophages that have dark granular material, which is what hemosiderin looks like on a diff-quick stain. And on the right, you see a combination of follicular cells, which are the dark purple nuclei, which look a little bit more orderly. The light pink is colloid. And then you see this kind of brown, granular cellular material, which are the hemosiderin macrophages that just are floating in the colloid. Colloid comes in two basic forms on an FNA. You have watery colloid, which you can see in a diff-quick stain, which I'll show you momentarily on the next slide. And you should also be aware that blood serum can mimic watery colloid. So there's certain artifacts that are associated with watery colloid that needs to be identified in order to determine that it's colloid. You also see dense colloid, which looks a little bit more thick, and it looks like it's irregular in shape. It's translucent, homogeneous material. There's no nuclei that you can see in colloid. So on the left, you see thin colloid, and if you notice, it has this kind of cracking feature. It looks like stained glass, and this is what's called stained glass artifact of colloid, and then you see some benign follicular cells right in the center there. On the right, you see thick colloid, which is, the irregular, amorphous chips of thick colloid. There's no nuclei present, and the density looks pretty homogeneous. Also in the benign category are the thyroidities, which can be associated with inflammatory or autoimmune issues. You have acute thyroiditis, which is not commonly aspirated. You also have granulomatous thyroiditis or subacute thyroiditis, also not commonly aspirated. And then you have also Hashimoto's thyroiditis, which is an autoimmune thyroiditis, and that actually is very commonly aspirated. Always thyroiditis needs to be correlated with ultrasound findings. There are specific ultrasound findings associated with thyroiditis. The thyroid will be microcystic or spongiform in appearance. It can also be diffusely hypervascular. It can also be hypovascular, but in Graves' disease or thyroid storm or thyroid toxicosis, the hypervascularity is readily apparent on ultrasound when you do power Doppler. And as always, serologic findings need to be correlated with the cytologic and the ultrasound findings in order to put the whole picture together for autoimmune thyroid disease. In granulomatous thyroiditis, you usually see a clinical picture of a post-viral syndrome. The patients will have a painful thyroid. It's usually a young woman who presents with fever, chills, fatigue. Usually they're not aspirated because the clinical picture is very clear. However, when the patient is not in pain and there's a nodule present, aspiration biopsy may happen. It's not going to be a very cellular aspirate, and the patient is not going to tolerate it well because it's going to be painful. Giant cells or granulomatous picture may be seen with chronic inflammation, and you don't see Hürthle cells, unlike Hashimoto's thyroiditis where you do see Hürthle cells. And this is a photomicrograph of giant cell thyroiditis, where you see there's numerous cells which have a lot of nuclei in it, and those are all giant cells. So Hashimoto's thyroiditis is also commonly seen on aspiration biopsy. On the left-hand picture, you see, a very heavily lymphocytic picture where you also see Hürthle cells. Hürthle cells are very common in lymphocytic thyroiditis. The upper right-hand picture is a Papanicolau stain of purely lymphocytes, which can also be seen, as I mentioned before. There can be a purely lymphocytic component and no follicular cell component seen. And then on the lower right, you can see Hürthle cells and also associated with lymphocytes. This is a case of a patient that I made a diagnosis of Hashimoto's thyroiditis. If you notice, the ultrasound picture on the left shows a very irregular, heterogeneous thyroid, where you see this is the nodule here. It's kind of spongiform. There's some microcysts present. Upon aspiration, there are numerous lymphocytes. There's Hürthle cells and follicular cells seen. So follicular lesions are the categories that include both nodular goiter and follicular neoplasms, including follicular adenoma and follicular carcinoma. These are category 5 lesions. Goiter, nodular goiter, or adenomatous nodules are in the benign category. How do you determine whether something is a follicular adenoma, which is a neoplastic lesion, versus a goiter, which is not a neoplastic lesion? Well, goiters certainly are more common than follicular adenomas. They usually appear as multiple nodules, whereas follicular adenoma may be a single nodule. The follicular adenoma is encapsulated, where a goiter may or may not be. The degree and the size of the follicles will differ. There's also a difference between the cell appearance inside the nodule versus the cell appearance outside the nodule. This is, however, a more these last two are more of a histologic picture than a cytologic picture. We don't know really what the cells look like from inside to outside the nodule cytologically, so we kind of don't have that information available when we do an FNA. You don't see invasion or metastasis in either one of these. However, capsular invasion is assessed histologically, not cytologically. Cytologically, there are different degrees of between colloid nodule or a cellular benign nodule versus a follicular nodule. And this has to do with, the cells that are seen, the number of cells, the pattern of the cells, and if there's a follicular pattern or a microfollicular pattern, they're going to be the microfollicular pattern in a solitary nodule will favor a diagnosis of a neoplasm or a follicular adenoma or carcinoma. Whereas if there are multiple nodules in a honeycomb pattern, you may favor nodular goiter. The risk of neoplasm in a zone 1 lesion is low, whereas in a zone 3 lesion is about 40%. And the risk of cancer is very low in the colloid nodule, but in the zone 3 or follicular nodule, it's more moderate. Now, a lot of these features, these things are obviated by the advent of molecular testing, because if these nodules are, if I had a zone 3 nodule, for example, or it was a class 3 nodule, I would probably send this for molecular analysis, and we would have a better idea of what's going on through the results of that. So this patient was seen, and this is a ultrasound of the right thyroid gland. This is a very large nodule. In subsequent lectures, I will get into the ultrasound features and what they mean, especially in terms of the ATA guidelines. But this is a solitary nodule that has a mostly solid appearance. And what I saw here were benign follicular cells in sheets. And you can see the nuclei are round, regular, and evenly spaced. When you look at the histology of these nodules, you see pretty much the same thing. The histology will recapitulate the cytology in these cases. And when you have tissue follow-up, you'll see that this is an adenomatous nodule. There's the pink is colloid surrounded by small, evenly spaced follicular cells. These are also follicular cells, which there are abundant follicular cell groups. They are arranged in microfollicles, meaning that they're arranged in small clusters. Some are single, but mostly they have like small little acinar arrangements or microfollicular arrangements. And then they turn out to be a follicular adenomatous nodule where you see very little colloid. For example, when you go back, you see very little colloid. And here you also see very little colloid. And what colloid you see is very thick. Hürthle cells, as I've mentioned, can be metaplastic or they can be neoplastic. All the features need to be taken into account when evaluating the presence of Hürthle cells. Is colloid present? Usually, the more neoplastic a nodule is, the less colloid is present. Is there a single population of Hürthle cells, or are they mixed? Or is there another population that are just benign follicular cells? They may be metaplastic Hürthle cells. Are there cystic changes? This can also mean that the Hürthle cells are metaplastic. Are the lymphocytes present? This can be a picture of Hürthle cells in association with Hashimoto's thyroiditis. And what are the ultrasound features? All of these things need to be taken into account when you're evaluating the presence of Hürthle cells and what they mean. So this is another ultrasound of a patient who had a large dominant nodule. This is a large nodule. It's heterogeneous. It has cystic and solid features. There's hyper and hypoechoic features. And there's also, there's areas that look a little more echo-dense and a little more echo-lucent. And the cytologic pictures on the Diff-Quick stain immediate assessment showed Hürthle cells. So I called this category 3 suspect Hürthle cell nodule. This is a cell buck that was performed. As you can see, there are strips of Hürthle cells with the abundant pink cytoplasm, and you also see these hemosiderin macrophages which correspond to the cystic or hypo or anechoic areas on the ultrasound. So different degenerative and regenerative changes will favor a nodular goiter over neoplasm. So I've shown you pictures of hemorrhage, which are signified by hemosiderin macrophages, and cystic degeneration. Areas of fibrosis on an ultrasound will indicate long-standing nodules as opposed to rapidly growing nodules. So these kinds of changes will favor something that's been there for a long time, that's less likely to be neoplastic because neoplasms grow typically faster. And while people can have nodular goiters for many years, as well as overlapping and crowding of the nuclei. So the nuclear architecture and the pleomorphism, which means the range and size and shape of the nuclei, will favor a neoplasm over a goiter. So here is a pictograph of round, regular sheets of follicular cells.